All right, good morning. Thank everybody for getting up early here. And it's going to be a great couple of hours, somewhat jam-packed. Before we start, I just wanted to make a couple of comments about the Hope Foundation. As people know, it's turning 30 this year. And the Hope Foundation has provided, I think, particular support for our Lymphoma Committee. I've been part of this committee for more than 20 years. And the number of grants and travel funds and other things that Hope has funded has been really significant. So there are a number of online links that you can look at to read about that. We're celebrating that, I believe, at the reception tonight. And I just encourage you to think about giving something to the Hope Foundation to give back. One of the things we're looking for is strong participation this year. So it's more, I think, about showing the support even than the amount of support. So they have a booth downstairs, or you can go online. And I'll just remind you that the Hope Foundation has a number of other grant opportunities with applications that are due over the next few months. I think that every single one of these we've had a member of the Lymphoma Committee get over the last 5 to 10 years. So it's a great opportunity. And if you're interested in any of these opportunities, Sony and I are always happy to write letters of support and provide guidance. So let us know. And with that, I'm going to turn it over to Dr. Smith.
So good morning, everybody, and I'll add my warm welcome to this beautiful morning in Chicago. We have a really packed agenda, as Jonathan just said, and I'm really excited to kick it off with a mini symposium of sorts, focusing on diffuse large B-cell lymphoma and really focusing on the relapsed and refractory setting where we have a trial. We had a really great kickoff meeting yesterday for S2207, and I'm just really thrilled to give everybody some of the background and then some of the detail. So to kick off the symposium, it's my pleasure to invite Dr. Laura Hilton, who has traveled here from Vancouver. She is a staff scientist in David Scott's lab and has had some really incredible work over the last few years, including the double hit signature and some other, new ways of thinking about diffuse large B-cell lymphoma. Dr. Hilton, welcome. Thank you for traveling all the way from Vancouver.
Morning, everybody. Thank you so much for the opportunity to speak to you today. I'm really excited about this work that I'm going to talk about today. So let's get into the biology and evolution of relapse in DLBCL. I have nothing to declare. So DLBCL, while an aggressive disease, is actually curable, and around 60 to 70% of patients will achieve a long-term remission. But for the 30 to 40% of patients who don't achieve long-term remission, outcomes are very poor. Currently, treatment at relapse might include one of several salvage chemotherapy regimes. We can perform autologous stem cell transplant for patients that are eligible. And more recently, we've added cellular therapies to the toolbox at relapse, including CAR T-cell therapy and bispecific antibodies. And so for today, I want to address the questions whether relapsed DLBCL has unique biology that distinguishes it from diagnosis, and whether there's different types of relapse and should they all be treated the same way. So before we can dig into the question of unique biology at relapse, let's just refresh what we know about relapse or about the biology of DLBCL at diagnosis. So among the aggressive B-cell lymphomas, the first step in classification, regardless of the system you're using, is going to be morphology. And among the tumors with large B-cell morphology, they're typically first stratified based on the presence of rearrangements. So tumors with both MYC and BCL2 rearrangements, or depending on the classification system, with MYC and BCL6 rearrangements, are classified as high-grade B-cell lymphoma double hit. And then it's recommended under any of these classifications that the tumors without those rearrangements, the DLBCL NOS, are further stratified according to their cell of origin subtypes, either by immunohistochemistry or preferably by gene expression profiling. And so the reason that this cell of origin stratification is important is several, including that we know that there's clear, distinct biology between these groups, but there's also important differences in outcomes. So on the left, we see outcomes for a population-based cohort of patients treated with R-CHOP in BC. And we can see that the GCB patients in orange here have superior outcomes compared to the ABC patients shown in blue here. And we can further stratify the GCB patients, separating out a group of tumors that express the dark zone signature, and patients with dark zone signature positive tumors have the worst outcomes, only about 50% freedom from progression over 2 years. And that leaves behind a group of GCB DLBCLs with excellent outcomes, almost 90% freedom from progression over 2 years. So we've more recently begun also classifying DLBCLs according to genetics, and this captures additional heterogeneity that is not fully captured by the cell of origin gene expression classification. But there are parallels between these systems, and you can see here that, for example, the MCD DLBCLs, which are typically characterized by MYD88, L265P, and CD79B mutations, among others, are strong ABC tumors. And then at the other end of the spectrum, we have the EZBs, which are almost always classified as GCB by cell of origin. And there's different outcomes associated with these groups as well. And the two groups with the worst outcomes that we're probably most likely to see enriched among cohorts, representative cohorts of relapsed DLBCL, are the MCD patients with 5-year overall survival of only 40%. And then the EZB patients that express the dark zone signature. So these are typically referred to in the literature as EZB MYC+, and these have less than 50% overall survival over 5 years. And really the promise of these is that we're going to be able to identify targetable vulnerabilities in these patients and provide therapy that's targeted to the unique biology of their tumor. So with that in mind about diagnostic DLBCL, we can now look at relapse and how it differs. So this is a study from our group published in 2020, and we looked at the largest to date cohort of relapsed DLBCL. We used ctDNA from 135 patients taken at relapse and compared it to an unmatched cohort of diagnostic DLBCLs and looked for mutations that were enriched in the relapse time point. And there were a few things that came up as enriched, including MS4A1, which encodes CD20, and TP53, for example. But there's some confounders here. So these enriched features could be explained by one of several things. They could be drivers of primary treatment resistance. So they may be innate at diagnosis and just have persisted throughout treatment. They could be clonally expanded following treatment, so absent at diagnosis and expanded as a consequence or as a result of selection from treatment. And they could also be associated with molecular subtypes that are more likely to relapse. So without accounting for the different heterogeneous structure of the cohort, we could just be looking at things that are more common among groups that tend to relapse. But serial samples can at least partly help us to distinguish these possibilities. So we did have several serial samples in this cohort. And what we saw was that consistently these MS4A1 mutations clonally expanded from diagnosis to treatment. They were absent or present in very low prevalent subclones and became clonal at relapse. So this suggests a selection for these mutations. And then in contrast, TP53 mutations were clonally stable and present at similar cancer cell fractions at diagnosis and relapse. We can also use gene expression to compare diagnostic and relapse tumors. There haven't been a lot of studies on this yet, but this study published earlier this year looked at paired diagnosis and relapse DLBCL. And when they performed principal component analysis looking at the variation, they saw that there was less variation explained by diagnosis versus relapse as compared to ABC versus GCB. So they separated their cohort according to cell of origin subtypes and looked for signatures of relapse within ABC and GCB separately. And within ABC, they were able to identify a 30 gene signature associated with relapse. And when they applied that signature to diagnosis, it was prognostic for outcomes in ABC DLBCL. So this really underscores the importance of considering your biological subgroups in studies of relapse. And then in the era of CAR T cell therapy, we've seen several studies so far look at gene expression or genetic features associated with CAR T cell success, whether or not patients achieve a durable response. And in this study published in Blood last year, they performed whole genome sequencing of patients that had received axi-cell. And they identified several genetic features associated with durable response or lack of durable response. And things like chromothripsis and double minutes were associated with worse outcomes in CAR T. And as we've begun a reanalysis of this cohort as well. And what you can see here is that the proportion of EZB and MCD tumors is about twice as high as what we would see in a representative diagnostic DLBCL population. So we think that most of these EZB tumors are probably dark zone signature positive. And that explains why we see more of these subgroups within these relapsed DLBCLs. And then there was an RNA-seq study looking at patients treated with liso-cel as part of the TRANSCEND study. And among several gene expression signatures associated with the tumor microenvironment, they also found that patients whose tumors were positive for the dark zone signature had inferior outcomes relative to patients that were negative for the dark zone signature. So this shows that features that we associate with outcomes at diagnosis are still also associated with outcomes, even in response to CAR T cell therapy. So this is not, we don't think necessarily a biologically agnostic therapy, and there's potential biological subgroups that will predict response to CAR T. Okay, so now on to the question of whether there are different types of relapse. So to answer this question, we were interested particularly in relapse timing, based on the clinical observation for many years that patients with primary refractory disease do more poorly than patients who relapse much later in their disease course. So to answer this question, we looked at 221 patients who had relapsed DLBCL in BC. All of these patients received frontline R-CHOP-like chemotherapy, and all had second-line treatment with intention to treat with consolidative stem cell transplant. And we stratified these according to different relapse timing categories. So primary refractory was less than 9 months from diagnosis to relapse. This translates to roughly 3 months from the end of treatment. Early relapse is 9 to 24 months from the time of diagnosis, and late relapse is more than 24 months. And so when we look at response rates to that second line chemotherapy, we see that the late relapse patients had a much higher, significantly higher response rate relative to both the early relapse and primary refractory groups. And this translated also into a increased rate of patients receiving the stem cell transplant that they were intended for. Looking at outcomes from the time of progression, you can see that the late relapse patients here in green do much better than both the early relapse and primary refractory patients. And then looking at progression-free and overall survival from the time of transplant, again, we see much better overall survival and progression-free survival among the late relapse patients. So it does appear that there are huge differences in outcomes, at least, between late relapses and early and primary refractory disease. So what biologically distinguishes these different relapse timing categories? So to address this question, we assembled a large molecular characterization cohort. Together, we gathered serial archival paraffin biopsies from a total of 129 patients. We performed MYC, BCL2, and BCL6 break-apart FISH to look at rearrangements across 117 of these patients. We used digital gene expression profiling, so the nanostring DLBCL90 assay on 91 of these. And most importantly, we performed whole genome or exome sequencing of 73 patients, and we complemented the whole genome sequencing with very deep targeted sequencing to really dig in looking for subclonal variants that would inform on tumor evolution. So here's a snapshot of what the cohort looks like. We have it broken down by primary refractory, early relapse, and late relapse patients. The biggest take home here, the DLBCL, the diagnostic DLBCL is all lined up on the first axis here. Several patients had a prior indolent lymphoma diagnosis, 31 out of the 129 in total. And you'll notice that this is skewed towards late relapse, and that's in part because of the historic sampling bias. So patients with early relapse or primary refractory disease are less likely to be rebiopsied at the time of relapse. And we also had a requirement for germline DNA in order to do our clonal analysis. And it was harder to get that material from early relapse and primary refractory patients as well. So we first looked at the concordance of mutations between these. So these are oncoplots that just show the mutation profile of the tumors. On the top here are mutations that are exclusive to the diagnostic tumor in each pair. The bottom are mutations that were exclusive to the relapse tumor, and then the middle shows the mutations that were shared between the two. And so as the time to relapse increases, in the late relapses especially, the number of mutations that's exclusive to the relapse tumor increases. But somewhat counterintuitively, so does the number of mutations exclusive to the diagnostic tumor. So overall, they share fewer of their mutations. And so you can see that here, the x-axis shows the total number of mutations in a sample, either all variants or coding variants only. And in the primary refractory and early relapsed groups, the number of mutations that are shared between the tumors is almost perfect unity with the total number of mutations in the tumor. But then in the late relapses, we see this association almost non-existent. So only a fraction of the mutations found in the tumor are shared with the other tumor. And we do see a time correlation here as well. So the longer the time from diagnosis to relapse, the more mutations are unique to both the diagnostic and the relapse tumor. And we see this both in all mutations and within just the coding mutations in these pairs. So we see this strong mutational divergence, but does that also correlate with biological divergence? How biologically similar or dissimilar are the diagnostic and relapse biopsies? So we first looked at the consistency of recurrent rearrangements, and as you would expect, BCL2 rearrangements by FISH were perfectly concordant. So tumors that had a BCL2 rearrangement at diagnosis also had that rearrangement at relapse. And we confirmed this with whole genome sequencing as well. The breakpoints were identical, and this is consistent with their origin early in lymphomagenesis, arising from errors in VDJ recombination in the bone marrow. And then I'll just contrast that with MYC rearrangements. We didn't see a lot of cases with MYC rearrangements in this cohort, and overall the concordance was high. Among the cases where there was a MYC rearrangement at either time point, the discordance based on FISH was 30%. And if we dig into what the actual rearrangements were, we found 2 cases where we were able to identify MYC rearrangements at both time points. These are both from late relapse patients. These MYC rearrangements are occurring on the background of a BCL2 translocation. So these tumors are all double hit. And we found that the diagnostic and relapsed MYC rearrangements were different. So one tumor had an IGH rearrangement at diagnosis and IGL at relapse. The other tumor had IGH at diagnosis and a MYC-PAX5 rearrangement at relapse. And so this shows that these tumors, while having a unified BCL2 rearrangement that was obviously shared with the last common ancestor, the diagnostic and relapse tumor each independently acquired their own MYC rearrangements. We next looked at the consistency of cell of origin subtypes. We also did this for the dark zone signature and saw very similar results. Overall, we see only 7% frank discordance across this cohort, so switching between ABC and GCB. And we saw that this increased with time to relapse. So there were no examples of discordant classifications in primary refractory disease and 11% in late relapse. And the correlation between the scores that are used to assign the cell of origin classification was weaker also in late relapse. So they drift a little bit further apart. And then looking at the consistency of the genetic subgroups, we see also that these are highly concordant, no discordance in primary refractory cases, and actually quite little discordance in late relapse even, where we see that most of the discordance, so the discordant cases are highlighted here in bolder colors. Most of the discordance involved switching from one class to a composite class or from one class to other or vice versa. So not big shifts. There were only 2 examples in this whole cohort of direct switches from a single class to a different single class. So what's going on with the mutations that might explain this pattern? So in primary refractory disease, here we see the mutations that we found in either of the tumors. On the x-axis is the variant allele frequency in diagnosis, and y is the variant allele frequency at relapse. And we see that these are strongly correlated. Almost all of the mutations are shared between these tumors. There's very little tumor evolution taking place from diagnosis to relapse in this case. And then looking at late relapse, and a pattern that we also saw in a small number of our early relapse cases, we see much greater patterns of tumor evolution here. So in this MCD example, there's a smaller cluster of mutations that are shared between the two tumors. This includes things like the MYD88 L265P mutation, but then each tumor has independently acquired mutations that are different from the other tumor. We saw the same thing in this example with EZB, a small shared subclone or small shared set of clonal mutations, including CREB-BP, and then most mutations arose independently on each branch. And I just want to highlight that we saw some of the same mutations recurring, not same mutations, but same feature, same genes mutated across each of these. So in this example, the MCD tumors each acquired independently mutations in ETV6, PIM1, BTG1. These are features commonly associated with the MCD subtype. And then in the EZB example, we saw each tumor independently acquiring mutations in things like FOXO1, BTG2, et cetera. So this leads us to this idea that the tumors are sharing a common precursor cell, and that this common precursor cell is constraining the evolution of these tumors. So in the example of primary refractory disease, the diagnostic and relapse tumors are really unified by a chemo-resistant clone. And there's not a lot of mutations that distinguish the diagnostic tumor from whatever the last common ancestor is of these two tumors. So this branch length sort of represents the number of mutations that are acquired in that time. So treatment might eliminate a small subclone of this tumor, but in general, what you're left with is a chemo-resistant subclone that doesn't really need to acquire new mutations in order to grow out into a full relapsed tumor. And so we end up with a large number of mutations shared between diagnosis and relapse. And then in late relapse, in contrast, we think that they're unified by this common precursor cell, which has a small number of mutations. That CPC, its offspring, its daughter cells have to acquire many mutations to go on to become a full lymphoma. Treatment pretty much eradicates that population and reverts back to a CPC population, which then needs a lot of time to acquire mutations again to become an overt lymphoma once again. And so the diagnosis and relapse share few mutations, and we think that this means that this relapse tumor in late relapse is effectively treatment naive. And this helps to explain why we see such good outcomes in these patients. And we also think that this helps to explain the biological convergence that we see. So not only between different classification systems, the overlap between the Harvard and the HMRN classification systems, as well as LymphGen, but we also think it helps to explain similarities that we see between these DLBCL genetic subgroups and various indolent lymphomas. So for example, MYD88 L265P mutations and CD79B are often found in lymphoplasmacytic lymphoma. So we think that this points to a shared common precursor cell that defines the risk of a cancer becoming one of these indolent diseases and is strongly associated with the evolution to one of these aggressive lymphoma subtypes. So in conclusion, we've shown that there's high levels of concordance of molecular subgroups between diagnosis and relapse, and that's true regardless of relapse timing. Primary refractory tumors are genetically largely unchanged. So this shows that they have inherent treatment resistance that exists at the time of diagnosis and helps to explain why they respond poorly to further chemotherapy. Late relapses are essentially new DLBCL, and their high overall response to second-line chemotherapy suggests that they are essentially chemotherapy naive, quite responsive to second-line treatment. The concordance of molecular subgroup that we see in late relapse, we think is a result of this constrained evolution from a persistent common precursor cell population, and that the mutations in that CPC constrain what possible mutations can arise, and what the ultimate biological features of the DLBCL will be. We think that it's important to consider characterizing the relapsed tumor, especially if you're using a precision medicine approach that depends on the existence of specific mutations. So if you need a particular hotspot mutation, you shouldn't assume on the basis of its presence at diagnosis that it will also be there at relapse. And lastly, primary refractory and late relapses, I think this is most important, should be considered distinct entities. And one thing that we'd like to work on is whether there's an optimal threshold, either based on time or based on the degree of divergence between diagnosis and relapse, by which to define how exactly to stratify primary refractory and late relapse. And with that, I just want to acknowledge the work of all of my co-authors on this study, and especially my mentors, David Scott and Ryan Morin. And with that, I'd be happy to take any questions.
We can sit up there. Dr. Hilton, that was phenomenal. Thank you so much for being here and for sharing that data. I'm going to open it up to questions, but just as people are coming up to the podium, and you can also just, oh, go ahead, Jim. Yep, go ahead.
Great talk, of course. I was just wondering, was there anything sort of characteristic for the original molecular phenotype or genotype of the DLBCL that were more characteristic of the late relapsers?
So like, if I compared the late relapses to the primary refractory, were there. So we didn't dig into that a lot, in part because of relatively small numbers of primary refractory cases. So I don't know if we had the power to actually determine what was unique to primary refractory disease. But that's definitely something outstanding still, is what might exist at diagnosis that would help us to predict who is going to have primary refractory disease. Yeah.
Was there anything also in terms of the time, because 2 years versus maybe it was like a 4-year or 5-year relapse? Was there anything like earlier in terms of the late relapsers that was characteristic, or were the late relapsers very divergent?
The late relapses were pretty consistently divergent. I don't think there were any examples where we saw like unity in the mutations between the diagnostic and relapse tumors, but it did get a little bit murky in the early relapse cases. So it was hard to, I think that we're going to be able to define an optimal threshold at some point for either divergence or time to relapse, where we'll be able to say, this is the cutoff.
I was wondering if you had a sense of how many of these patients received radiotherapy as part of their kind of original treatment, and if that had any influence on, kind of diversity of mutations, mutational frequency, all that kind of thing.
I'm sorry, which kind of therapy?
Radiotherapy.
That's a great question. All of these patients, as far as I know, were initially treated. Actually, some of the follicular lymphomas may have been treated with radiation previously. So we didn't dig into that. We also have a cohort of transformed and progressed follicular lymphomas, and we're looking into the influence of treatment on clonal evolution in that context as well. Yeah, that's a great question. Thanks.
So I had a question. So in the very beginning, you were showing how P53 is a stable mutation. Do you know if there was any association with CHIP?
I don't. Because we were looking at ctDNA, I think CHIP mutations probably would have appeared to be, it would have been hard to distinguish from a somatic mutation in that context. But because we did see them consistently also in the diagnostic tumor, that I guess, yeah, I don't know. That's a good question. I don't think we have what we would need to confirm whether or not CHIP is the explanation for that yet. Yeah.
Yeah, I was curious because, for the late relapses, you've got that sort of smoldering clone, if you will, that just kind of can, have a different evolution to a different distinct lymphoma, which I think is really a compelling concept. Just wondering if there is some clonal background, in those patients, when you're looking at that CPC and their germline genetics.
Yeah, so we do want to go looking for a population. We think possibly the bone marrow could be a resident population for those CPC cells. But whether or not it is detectable the way that CHIP is, I think that remains to be seen. Yeah.
And then maybe just one last question, unless there's anybody else. what are like the plans to sort of broaden or validate this, because this is 129 patients. What are your next steps, looking for other samples?
Yeah, so we started with the outcomes from that representative population-based set of cases. And so we really want to go back to that set. We have biopsies from most of them. We want to sequence all of the tumor material we can get our hands on, both the diagnostic and the relapsed samples, and see if we can use that to help address this question of what is the optimal cutoff for divergence or time to relapse, and can we identify features at relapse that are predictive of primary refractory disease.
Great.
Yeah.
Okay. Anyone? Any other questions? Thank you again. That was really fantastic.
Thanks.
Okay, so that is just the perfect setup for a trial that we kicked off yesterday. I'm going to ask the study chairs, Dr. Amengwal and Dr. Reagan, to come up here for the second part of this mini symposium on DLBCL. And we're going to start by going over the evolving treatment landscape, now from a clinical perspective for how we treat patients. And I'm going to have Dr. Patrick Reagan, who is an associate professor of medicine at Wilmot Cancer Institute, one of our Lymphoma Committee very active members. And he's going to talk to us about the treatment aspect.
Okay, so I'm going to provide an overview of the treatment landscape, which is a much more daunting task than it was a few years ago. These are my disclosures. So first, going to discuss sort of where we were. So for 20 years, it was salvage chemotherapy with consolidation with an autologous stem cell transplant if patients responded. Where we are now with the, I would say plethora of targeted therapies that we have at our disposal, discussing CAR T cells, bispecific antibodies, and other targeted treatments. And then where we need to go, optimizing therapy with our current products. How do we incorporate other novel agents into these therapies? How do we sequence treatments? So how do we use these various targeted therapies that we have? How do we sequence them? What's the optimal sequence of that? And then also thinking about where we want to go to, which is really truly using personalized medicine. So where we were, autologous stem cell transplant. This was the large B-cell lymphoma treatment paradigm in sort of early 2017 before the approval of Axi-cel. And really, if a patient had relapsed or refractory large B-cell lymphoma, we would determine if they were a transplant candidate. If they were, they would receive platinum-containing salvage therapy and then have a consolidation with an autologous stem cell transplant if they responded. If they weren't, we would consider clinical trials. We would potentially give palliative chemotherapy and then also consider off-label targeted agents like lenalidomide. Autologous stem cell transplant was sort of established as a standard therapy with the PARMA trial, where it was a randomized controlled trial in which patients with intermediate or high-grade non-Hodgkin lymphoma. Patients received 2 cycles of salvage therapy, followed by randomization to consolidation with transplant versus continued conventional therapy. And in the transplant arm, both EFS and in the curve shows that OS was superior to conventional treatment. In the rituximab era, the CORAL study was a randomized study of R-DHAP versus RICE, followed by autologous stem cell transplant. And the 2 top curves, the median PFS and OS were similar between the 2 groups. And I think what we really learned from this is that patients who had prior rituximab exposure, particularly those patients who relapsed before 12 months in curve C, had an inferior EFS. I think this is telling us that the absolute benefit that patients who received more effective frontline therapy was much less in the rituximab era. And where we are now, targeted therapy for large B-cell lymphoma. I think this is a timeline of approvals. So I didn't make this to scale because this would sort of look like when they talk about the timeline of the Earth in human existence. But the PARMA study was published in 1995. CORAL study was published in 2010, and then really since 2017, we have either had a new agent approved or we've had an update to a label. So Axi-cel was approved for 3rd line in 2017. Tisa-cel was approved soon after in 2018. Pola-BR was approved in 2019 2020, we had tafasitamab and lenalidomide as well as selinexor. Liso-cel was approved in 2021 as well as Lonca-T. 2022, both Axi-cel and Liso-cel had a update to their label where we could use this in second line for refractory patients, but then also Liso-cel for transplant ineligible. And then finally, in 2023, we've had the recent approvals of epcoritamab and glofitamab. This is a table sort of summarizing response rates and 2-year PFS of patients receiving CAR T cells on the pivotal studies. So there was a variation between patients apheresed and patients dosed throughout the trials. There was some variation in response rates. This was the modified intent to treat, which is not really intent to treat. This was just the patients who were dosed with the product, and relatively similar 2-year PFS in those patients who were actually dosed with the product. And then median OS much higher than what we have seen with historical controls. Based on these data, a series of studies were designed in which patients were with relapse or refractory DLBCL were randomized between platinum-containing salvage therapy and CAR T. The first study that was reported was the ZUMA-7 study, in which patients were randomized between Axi-cel and platinum-containing salvage therapy followed by transplant if they had a PR or CR. And then patients with disease, this was all patients with disease relapse within 12 months of diagnosis. There was no bridging apart from corticosteroids and no formal crossover. Now, the 2-year EFS was superior in the Axi-cel arm, 41% versus only 16% for our standard of care in this population. And with longer term follow-up, there is an OS benefit as well. And in April 2022, the label was expanded to include patients with relapse within 12 months of chemotherapy in the second line setting. Although that has been more challenging to actually deliver that care to those patients truly in the second line setting. The Belinda study was the next study reported, Tisa-cel versus platinum-containing salvage. And this was patients with disease relapse within 12 months of completion of therapy. Bridging therapy with platinum containing salvage. There was crossover allowed. This was a negative study. There was no benefit to CAR T in this study. And then finally, the Transform study with our own Dr. Kamdar as the first author. So Liso-cel versus platinum-containing salvage followed by autologous stem cell transplant. And patients with a disease relapse within 12 months of treatment completion. All patients could receive a cycle of platinum-containing salvage and for bridging. And there was crossover allowed. And median EFS was superior in the Liso-cel arm. And again, the label was expanded in July of 2022 to include those patients with relapse within 12 months of chemoimmunotherapy. And then sort of finally in CAR T with the pilot study, this was patients with second line, were treated with Liso-cel in the second line, and they were considered ineligible based on investigator assessment for autologous stem cell transplant. The most common reason for ineligibility was age greater than 70, but there were some other things on the study that would make a patient ineligible. There were high rates of response and a median PFS of 22.6 months. And this expanded the label in Liso-cel for patients who are transplant ineligible. I think we had seen data from the pivotal studies that this was feasible in older adults and patients, but really it was largely the transplant eligible population on those studies. And so a summary for CAR T cells in large B-cell lymphoma. CARs are active in patients with disease resistant to chemotherapy or relapse after autologous transplant. Axi-cel and Liso-cel are superior to salvage chemoimmunotherapy, followed by transplant in patients with refractory disease or who relapse within 12 months. In other patients, we don't have data, and autologous stem cell transplant remains the standard in other patients. And as Dr. Hilton said, these patients do better with chemoimmunotherapy with later relapses. And then CAR T cells are feasible in the transplant ineligible population, though disease relapse remains a concern when 60% of those patients have relapsed by 2 years. And usually it's much sooner than that. Then we have a number of other agents that we can consider. So BRM polatuzumab, as I had mentioned before, has been approved. This was studied in a pretty heavily pretreated group of patients with relapse and refractory DLBCL. It was a phase 1b/2 trial, and there was a randomized cohort. And the objective response of BR-POLA versus BR was much higher, as well as were the CRs. The median PFS, OS, and duration of response were also superior in the BR arm. Role of polatuzumab is a little unsettled because of the POLARIX trial. And, certainly we're using it now. But as we have more of those patients who've been exposed to polatuzumab, particularly the population who is refractory to therapy, I think that will be somewhat diminished. I think an important point to note is that bendamustine really should be avoided in those patients prior to CAR T collection because of the association with inferior outcomes. Loncastuximab tesirine was studied in patients with relapsed and refractory DLBCL with 2 or greater lines of therapy. Had an objective response rate of about 50%, and about a quarter of patients had a CR. Median PFS was relatively short, but those patients who did respond had a reasonable duration of response. The greater than 3 events were mostly hematologic, and peripheral edema is common. And having used this a bit more now, I think the other thing to be concerned about is the skin rash with sun exposure can be a real issue. And then we have lenalidomide and tafasitamab, and this is ultimately what we chose as our backbone for S2207. This was studied in a group of patients with relapsed DLBCL. Initially, they excluded patients who had relapsed within 6 months, but then modified the protocol to allow patients who had relapsed greater than 3 months from treatment. Relatively high rates of objective response and CR. And then importantly, I think those patients who did respond, particularly those patients with CR that you can see in the curve, there is some durability to this response. And that has been maintained nearly 5 years out from treatment. So while this was, sort of a relatively favorable group of patients, there is a subset of patients, particularly if they respond. And if they have that response relatively early, you can see some durability with this, and pretty well tolerated with largely hematologic greater than 3 toxicities. I suspect most of us are not using 25 milligrams of lenalidomide, though, with many of our patients who are older that we're considering this for. And then finally, we have of the therapies that were approved besides the bispecifics, we have selinexor. So this was a heavily pretreated group of patients, relatively low rates of response in CR. I think that there are some patients that may derive some benefit from this. But really looking at this as largely a palliative option for patients with a relatively narrow therapeutic index. So the response rates are relatively low, and there are toxicities with this regimen. I think we've all been very excited about the approval of bispecific antibodies. So epcoritamab was studied in an open label phase 1/2 trial. Again, heavily pretreated group of patients, median 3 lines of therapy, and about 40% of patients had received prior CAR T. High rates of objective response and CR. Median PFS was relatively low, but again, median duration of response, patients are deriving real benefit from this. And those patients who do achieve CR, the duration of response has not been reached yet. I think toxicities are, there are some, I think certainly logistical issues with these types of therapies, with managing CRS and ICANS, trying to largely do that in the outpatient setting if possible, but the rates of severe CRS are relatively low. And there was really only in this study, there's really only 1 case of severe ICANS. Unfortunately, it was a fatal case of ICANS, but relatively low rates of ICANS with these products. And then glofitamab was studied on a similar open label phase 1/2 trial. Again, heavily pretreated, about a third of patients had received prior CAR T. This is limited duration therapy, so there's a fixed duration of treatment. Objective response about 50% and 40% CR. Again, median PFS is relatively short, but if those patients do achieve CR, we can see durability of response, and similar rates of serious cytokine release syndrome or serious ICANS in this group. So now I think this sort of treatment algorithm or suggested treatment algorithm is very different than it was just 6 years ago. So if a patient relapses within a year, the first question is, are they a CAR T candidate? If yes, proceeding with a referral for CAR T therapy, and then considering bridging, avoiding bendamustine if bridging is considered, or particularly treatment prior to collection. If they're not a CAR T candidate, I think in the third line setting, and potentially could consider getting it earlier, but with the approvals in the third line setting, considering bispecific antibodies, I think then we have some choices to make, and we really have no randomized data in this setting to consider. So consider lenalidomide and tafasitamab, can consider BR and polatuzumab or Lonca-T. I think that the most important thing about this is that really, regardless of their candidacy, I think a well-designed clinical trial is something that should be considered in this group of patients, given our lack of randomized data in this setting. I think those patients who are eligible for CAR T cell therapy, maybe that's a CAR T clinical trial, but I think we still have a lot to learn in this group. And those patients who relapse greater than a year, I think we're still asking ourselves the question, is this a transplant candidate? And if yes, and they respond very well to salvage chemotherapy, considering autologous stem cell transplant. If they don't respond to salvage therapy, then proceeding with CAR T cell therapy. If they're not a CAR T cell candidate, not an autologous stem cell transplant candidate, but may still be a CAR T candidate in considering liso-cel in that setting. And then if not, considering bispecific antibodies, lenalidomide, BR-POLA, and Lonca-T. Again, this is another group that we should be considering in clinical trials, particularly those patients who are not CAR T candidates. And finally, sort of really going to talk about a series of questions, because I think we lack a lot of the data that we need to make these treatment decisions, and certainly randomized data to make these treatment decisions. I think sequencing therapy is a question that many of us have. Should we avoid anti-CD19 agents prior to CAR T? I think we have some data now in secondary analyses of clinical trials that perhaps there is not antigen loss with tafasitamab, perhaps there's not antigen loss with Lonca-T. Are they effective after CAR T? We have very few data looking at some of our novel targeted therapies in the post-CAR T setting. How can we combine novel agents in the relapse setting? I think that's something that there are some studies that are ongoing, but we really have very, very few data in this setting. And what is the optimal treatment after CAR T? I think most of us would consider bispecific antibody therapy in that setting, but again, we don't have randomized data to support that. And I think another question is in those patients that we deem high risk, and I think hopefully we can start to implement some of the things Dr. Hilton was talking about, that we can identify those patients who may be at high risk, or perhaps using things like circulating tumor DNA to identify those patients who've had PRs or stable disease at day 30, and how can we focus on that population? And Dr. Hess is going to give some updates on S2114. So we have a study looking at consolidation of patients who have received who have achieved a PR or stable disease after commercial CAR T cell therapy. And certainly these are the types of studies that we need to see to try to see, can we intervene on that group early, who's at a higher risk of relapse, and can we sort of change the natural history of that scenario. In terms of personalizing therapy, commercially available treatments, we're doing that to some degree. Commercially available treatments can be tailored to patients' comorbidities, performance status, disease status, social support. Some patients don't have caregivers. Some patients live very far from the treatment center, and it's just not feasible for them to come for CAR T cell therapy. And particularly patients who have, who have challenges with travel, financial hardship, and certain prior therapies may make them ineligible for various treatments. And so we're doing this to some degree on a clinical basis. I think our goal is to tailor our current and future therapy to their disease biology. And so we've seen with some of our approved agents that the activated B cell subtype, the patients who receive both POLA-BR as well as lenalidomide tafasitamab, that's associated with improved activity in patients with ABC. And can we identify patients who are at high risk of disease progression? Again, can we intervene earlier in these patients? And I think I think as Dr. Hilton said better than I will on this one slide, this is a biologically complex, and targeted drugs are likely going to work in small subsets of these diseases. And I think that we certainly need trials that assess efficacy based on tumor biology. I think one of the questions we have is, can we actually implement a study where we are looking at the biology of disease and we're assigning patients based on the biology of disease? I think we've tried to do that in using gene expression profiling or using IHC, and even using those techniques, it's difficult. And that sort of the time that it takes to perform those assays is too long in a patient who has relapsed large cell lymphoma who needs treatment now. And so we need to be able to look back on our studies, and through correlative studies really understand who are these patients who are benefiting. And so that leads into what Dr. Amangwal will discuss, was S2207, in which we are randomizing patients between a tafasitamab lenalidomide backbone as the standard of care arm, and between two other combinations of tafalen plus zanubrutinib, tafalen plus tazemetostat. We are hoping, as Dr. Hilton suggested, that we are enriched for those MCD patients, that we're enriched for the EZB patients, and that we can learn something about how those particular groups do with these agents. And ultimately, our goal is that we can assign patients to therapy based on their disease biology. But I do think that we have a lot of work in enrolling patients to studies like S2207. I'm hoping that with our correlative studies, we'll be able to learn a lot about these groups. And with that, I will take any questions, and then we'll move on to Dr. Amangwal, who will discuss the study.
Thank you. So I think we'll go on to Dr. Amangwal's talk, and then we'll have questions for the two of you together.
Okay, this was fantastic. Thank you, everyone. Dr. Hilton and Dr. Reagan, that's a great introduction. And like Dr. Reagan said, hopefully, based on some of the work that Dr. Hilton did, we can target some of those sort of worst case scenarios with this clinical study. Okay, so from a broad perspective, the S2207 clinical study is a randomized phase 2 clinical trial. It will start with a safety run-in with a target population of patients with relapsed refractory large cell lymphoma. And the primary objective of the safety run-in will be to identify the recommended phase 2 dose. And this will occur in the first 24 patients or so, and patients will not be randomized, but will be assigned based on investigator's choice between tafalen plus tazemetostat or tafalen plus zanubrutinib. Once the recommended phase 2 dose is established, we'll move into the randomized portion that will, with the primary objective of understanding the progression-free survival between the experimental and control arms. And patients will be stratified based on cell of origin and whether or not they've been refractory to their last systemic therapy. They'll be randomized 1:1:1 to the control arm, which is arm 2 of just tafalen, experimental arm 1, which is tafalen plus tazemetostat, and experimental arm 3, which is tafalen plus zanubrutinib. So I think we can kind of skip some of the background about why we're going to this study. I think both the prior talks really kind of laid down that foundation. But essentially, we're trying to build on a backbone that's been successful using some biologically targeted agents to get in at the drivers that are influencing this disease. Okay, so our primary endpoint for the study is progression-free survival, as I mentioned, and this will be a randomized 1:1 clinical study. We will be stratifying patients by cell of origin, and this will occur by Hans criteria, just using immunohistochemistry staining to identify germinal center versus non-germinal center diffuse large B-cell lymphoma. And we'll also be stratifying patients between having been refractory to their last systemic therapy, yes or no. So this would be, great tool, perhaps if we're going to be collecting samples, perhaps we can collaborate with Dr. Hilton in the future to look at some of this biology. Some statistical considerations. So we're assuming 40% of patients are GCB and 60 are non-GCB, and assuming a 12-month PFS in the control arm is 30% for GCB and 50% for non-GCB. This leads to a sample size of about 120 eligible patients and 60 patients per arm. And we're hoping that we will improve the overall survival across all the groups from 42% to 60.5%. Okay, so going into some key eligibility, so the histology that's included is really pretty much all relapse refractory large B-cell lymphoma, including transformed disease, follicular grade 3B, high grade diffuse large B-cell lymphoma with MYC, BCL2 or BCL6 translocations. And we will not be including a Richter's transformation from CLL. As mentioned, we need to identify cell of origin for eligibility. Patients must have measurable disease by PET scan within 28 days. They must not be a candidate for autologous stem cell transplant, and that is determined by the local investigator. Patients may participate if they relapse after transplant or cellular therapy. And patients may receive up to 5 prior treatments. One question actually who's come up is, does salvage chemotherapy and transplant count as one regimen? And we're going to say yes. And does bridge to CAR T count as one line of therapy? And we're going to say yes. So just keep that in mind. So the control arm, or sort of backbone that we're building on, is arm 2. And it will be given just standard of care, tafasitamab on days 1, 4, 8, and 15 for cycle 1, and then days 1, 8, and 15, and 22 for cycle 2, and then going as 2 to 3, and then days 1 and 15 going forward. And lenalidomide will start 25 milligrams daily for days 1 through 21 on a 28-day cycle. I like to note that this is a fixed duration study with 13 cycles, which adds up to about a year of therapy. For experimental arm 1, so we'll have the same backbone, but we'll add tazemetostat, which is an oral agent that will be given twice a day, continuously through days 1 through 28, and the dose will be determined by the phase 1 safety run-in. Experimental arm 3, again, same backbone, but we'll be including zanubrutinib, which will be given PO BID continuously for the 28-day cycle. And again, the dose will be determined by the safety run-in. As for the safety run-in, we'll be ensuring safety of the treatment combinations. There'll be 3 dose levels for each, but really starting hopefully just 2 dose levels. There'll be up to 12 patients per arm, and these arms have been open at activation. And I'd like to just stress there'll be no randomization for the safety run-in portion, and determination of which arm a patient goes on is based on the investigator's choice. So if you're evaluating a patient, you get to choose which arm they go on so long as there's slots available. And we'll be looking at tazemetostat 600 milligrams and 800 milligrams, which is the full dose, and zanubrutinib 80 milligrams twice daily and 160 milligrams twice daily, which is the full dose. We'll be collecting DLT information during the cycle 1 with weekly assessments and AE assessments. And we'll be patients in the safety run-in will be discussing on teleconferences every 2 weeks. And here's a table just outlining some of the toxicities that will trigger a DLT. Most of these are hematologic, and then there's a handful of non-hematologic toxicities that we'll be looking, but pretty standard type of DLT criteria. Well, for disease assessment, we'll be getting interim scans after cycle 2, so about cycle 3, plus or minus 7 days. And then additional assessment at cycle 6 is optional. We're trying to just make this easiest for patients, and it's really up to the local investigator sort of when you feel it's necessary to do scans after the initial scan, interim scan. There'll be an end of treatment disease assessment, and all patients must have an end of treatment PET CT And then if they do complete all the way through cycle 13, this will occur 3 to 8 weeks after completion. If they come off treatment early, it should be 3 to 8 weeks after completion of therapy. And if there's any suspected progression of disease, patients must have a PET at that time. And we're encouraging a biopsy at that time for potential exploratory objectives in the future. Follow-up, patients will be followed following discontinuation every 3 months for the first year, every 6 months, years 2 and 3, and CAT scan should occur every 6 months. And then if patient does progress, they'll be followed every 6 months for 1 year and then annually for years 2 and 3 after registration. We'll be collecting quite a bit of samples with the hopes of performing some correlative studies. Most of these will be peripheral blood, serial analysis for tumor DNA, circulating tumor DNA, looking for minimal residual disease and clonal evolution. So we'll be collecting peripheral blood at baseline and cycle 1, day 1, cycle 2, day 1 at end of treatment. We'll also be, and so we'll be collecting both EDTA tubes and Streck tubes for this. And then we're hoping to also evaluate the immunomodulatory effects of tafelen on T and NK T cell repertoire and expression of markers of exhaustion. And finally, we'll be looking at expression of CD19 and CD20 in pre and post treatment tumor specimens and PBMCs to correlate whether CD19 expression predicts response and to evaluate perhaps loss of CD20 at relapse. And so for that, we'll be requesting biopsy material prior to treatment. And then also if a patient progresses, if you can get a biopsy, that's not required, but optional. Because the targeted population is, patients not fit for transplant, and those who are often multiply relapsed, we're very interested in seeing if we can increase quality of life. And to measure this, we'll be incorporating patient-reported outcomes. And we'll be incorporating the FACT-G subscale score and the FACT-LIM total score at 3 months after randomization. And we'll be looking between the control arm and each experimental arm. And we'll be looking at quality of life over the 12 months. And so this is the timing of the patient-reported outcomes. The FACT-LIM will occur on baseline and then months 3, 6, and 12. And the pro-CTCAE looking at toxicities will be at baseline and at each cycle at the end of treatment. And these will be available both in English and Spanish. We're really fortunate to be working with patient advocates, and they've developed some great resources for patients getting ready to be enrolled on study. And so I encourage you to look for these resources on the CTSU website. Basically, there's a plain language summary, which is a tool that can really help guide patients in understanding the clinical trial and be great to go over this with patients as you're going over the consent form. There's also some beautiful graphics really kind of explaining how the treatment will be given and for both the safety run-in and the randomized portion. And there's also financial resources there. So with that, we'd love for you to open the study. We already have a patient enrolled, and we're really hopeful that this will improve the care of patients who are transplant ineligible refractory lymphoma, diffuse large B-cell lymphoma. And these are our contact information. If anyone has any questions regarding any components of the study, we're happy to talk to you anytime. Okay, thank you.
So this is open for questions or comments. And I might just add, one of the things that Dr. Reagan had touched on was just some of the limitations of access to CAR T cells and how, we address the challenge of relapsed large cell lymphoma, when you're not near a center where CAR T is easily available or for people who don't want to make that leap. I think bispecifics are, a challenge, but there's also some limitations there, particularly with getting that started. And those are, the durability of those, I think, are still, TBD for some of them. So I think the Tafalen backbone with limited duration therapy and with or without the two agents that we talked about, I think is a really exciting opportunity for patients who are older, more frail, and not eligible for some of the more aggressive therapies or don't have access. So I did want to just also acknowledge that this was a team effort. Thank you both for speaking today and giving us that background. This has been a discussion for several years. And, as is the beauty of SWOG, we had everybody pitch in from our patient advocates, of course, our statistical team here, but also the PROs that were built in and the correlative studies. I mean, this was really just a fantastic group effort. So I hope everybody will consider and open it. A question in the back.
So another radiotherapy question. So salvage radiation, does that count as a salvage line of therapy for this study, or is it not?
That's a good question. I'm not sure if we have that explicitly in the. I don't know. What should we do?
I think
That's a good question.
We'll have to discuss that, but
Yeah.
I sort of think if it's given on a consolidative basis, I would similarly to salvage and transplant, I would probably lump those together.
And then if you had like bridging with chemotherapy and radiation before CAR, would that be one line or two
Yeah.
lines?
I think any bridging would be considered one.
I actually think the protocol specifies systemic therapy for the lines of therapy.
Okay, thank you.
All right. Well, thank you both very much. So it's my pleasure to now welcome Dr. Lisa Rimza up here. Let me move this forward once. Actually, can you advance one slide? Thank you very much. So this is the last presentation that we have for today before we dig into some of the trial updates. But Dr. Rimza is the Getz Family Endowed Professor in the Department of Pathology at Mayo Clinic. And this particular presentation, we started with Dr. Friedberg telling us about the Hope Foundation and its impact and our involvement within our group. And I think this is just a really beautiful example of how the Hope Foundation is being put to action. We're going to hear about prediction of early progression of disease in follicular lymphoma.
Yeah, so thank you so much. It's really great to be here at SWOG meeting. I've been absent for a few years, so it's really nice to see some familiar faces. So as she said, this is a work that's funded by the Hope Foundation, and we've had a lot of people involved. The statistical modeling, I have to give complete credit to Dr. George Wright at the NCI, bouncing that off of Lou Stout, Colleen Ramsauer in my lab, and then Maziar Chu, Mike Hongley, and Jonathan have all been involved. So do I advance?
Oh, the other.
Oh, the other
there's
one?
Another mouse.
This
there.
one?
Yeah.
Okay, so so we all know probably about the EFS importance of EFS 24 from this paper from Carla Casullo and Jonathan Friedberg, published in 2015, about how patients who have early events, then this correlates with a poor outcome later on. And this was from a huge study from the National Lymphocare. So what is our goal? We want to not have to wait 2 years to see who's had an event. We'd like to know right up front who has an event. And we have a lot of experience using gene expression profiling to create different assays. And so we said, okay, can we make a predictor of EFS 24? I'm going to refer to it off and on as FL24CX, follicular lymphoma 24-month classifier. And the goal is to identify those patients who require, who maybe are going to have a more aggressive course and maybe require more treatment, but also to be able to really do efficient follicular lymphoma clinical trials. If you can enrich clinical trials for patients who are going to be having early events, you're going to be able to iterate those trials much more quickly. So we went back through the literature and a lot of work has been done. A lot was done using snap frozen tissues over the years. And so many of you may be familiar with the Dave papers from New England Journal of Medicine that first established immune response signatures 1 and 2. And immune response 1 being a poor outcome, 2 being a good, correlated with a good outcome, and you subtract one from the other and come up with immune response score. We also went through and picked the Hewitt genes, or the Sarah Hewitt's paper. This is from the PRIMA trial. Other people also call it the PRIMA 23 genes. So those are correlated with overall survival. Our colleague Stephen Ansel at Mayo Clinic in Rochester had the 2 publications with Dr. Yang in Blood, FOXP1 from British Columbia Cancer Agency paper. We also are the group that had developed the Lymph2 and the Lymph3 CX assays for cell of origin and DLBCL. So we selected all those same housekeeping genes so that we can use the same reagents across various tests in that lab. And then we had done a lot of initial modeling and came up with another 23 genes of interest. So we had 144 total genes from sort of frozen, snap frozen pan genomic studies that we wanted to see how many of these lift over well into paraffin embedded tissues, because that's what we're going to be dealing with, right? Blocks off the back shelf. So this is our final model. You can see the gene sets that I just went through, the number of genes in them. And then the third category is how well did they correlate between frozen and paraffin? And only some genes do. Some genes actually, the mRNA is just does not do well once you try to look at it in the paraffin. So we ended up with about 63 genes plus housekeepers, and then did all of the modeling on that and to end up with a 45 gene signature plus housekeepers. And you can see what the genes are there. So most of the PRIMA 23 genes, the Hewitt paper genes that were associated with bad prognosis, those are all listed there. IR1, those are all listed. Many of the Hewitt good genes, some of the IR2 and 2 of the Yang paper genes came out as significantly or into the model. And George Wright, who is really good at this, has slides and slides of all of the different ways that he attempted to model this and came up with this logistic regression model. This is his ROC curve. You can see a tiny red dot there where there's a clear inflection of the curve where he set his cut point. So this is some of the data showing cross-validation of this FL24CX assay, tenfold repeated 10 times. And we wanted to compare the different things that are out there in the literature. So the Hewitt or the PRIMA 23, just to let you know, that was modeled on overall survival, not EFS 24, but here's, it did pretty well. The green line is actually our initial model. If we showed this at ASH last year, but then subsequently George has re-looked at and come up with his final model, which we're calling the FL24, and I put 45, and that's his logistic regression. You can see that there's about 2/3 of the patients actually are in the pretty good category, and then about 1/3 are in the poor category. And you can see the difference of over 80% versus 60% achieving EFS at 24 months. Sorry. So then what was up next after we had this? We wanted to do an external validation. So SWOG SOO16 was something that we had available. And we thought this was part of the original kind of specific aims to look at, markers of outcome. So if you recall, this is an R-CHOP and a Bexar-CHOP arm. I put kind of same outcome. I mean, they have similar outcome. So we felt it was fair to use those 2 arms together. We did not use the original CHOP only arm. And we did a blinded tissue analysis. We didn't know, how these patients had done. And we did the risk group classifications and sent that to Hong Lee and Mike, who actually were able to get this done in time for the meeting. So that's fantastic. And this is from Hong Lee's email to me last week, showing the relative risk of having disease within 24 months after registration among patients who are classified as bad, likely not to achieve PFS 24, relative to patients who were classified as good, and that's likely to achieve. So the hazard ratio is 2.2, with the opposite being if you're in the good group, the hazard ratio is 0.53. So that was just fantastic. And this is what the curve looks like here. You can see the difference in 2-year estimate is 83% versus 62%. So it did correlate with some of the baseline factors. We were discussing this. It does seem to correlate with maybe stage and potentially the grade 3. So we're going to explore that a little bit further. And then Hong Lee also did a 15-year progression-free survival by FL24CX, and that was still quite significant. When we get to the overall survival, it loses significance, and but this is actually okay because our intention was not to predict overall survival, which is what everybody, when they look at genes associated with outcome, they're looking at that very, very long time point. And I think this is kind of the power of SWOG, that you have data that goes on for a very long time and you can see these kinds of things. What we're trying to do is say, what happens, what's predicting what's going to happen by 2 years. And that may be a different set of biology than looking at what's going to happen all the way out 20 years later. So what is up next for this? So then the question is, well, what about the other things out there? You know, we all know about M7 Flippy, and what about mutations? Because maybe that's really the most important thing. So I want to just mention the M7 Flippy paper that came out in 2015. If you look in the the panel A, there's a list of 7 genes there: EP300, FOXO1, CREB-BP, CARD11, MEF2B, ARID1A, and EZH2. These are associated with patient outcomes. And if you combine those with the regular Flippy score, the Follicular Lymphoma International Prognostic Index, you can get actually a better separation of those survival curves. So if you look in a panel C, the green is the poor outcome with the Flippy, but when you do M7 and Flippy put together, you get the red curve. So quite a bit more information gained from adding those mutations in. It's something I guess, as we talk about a little bit, who does this, how is it standardized, and that kind of thing, I think is always a question. And I just want to mention, because this gets glossed over quite a bit, the dropout of doing sequencing in formalin fixed paraffin embedded tissues. So this is just from that paper, from the M7 paper. If you look at their figure, their training cohort, they had 210 biopsies, 165 had good quality data, 79% did you get data out of it. The validation cohort, same thing, 140, 107 actually worked, 76% success rate. Not to brag too much, but the digital gene expression, the encounter system, we're actually running this clinically now for Lymph2 and Lymph3CX. We'll be doing dark zone signature clinically in the next few months. But we have about we have like a 98 to 99% rate we rarely, I mean, once or twice a year do we have a failure. We just published 134 cases, 100% success rate with all cases, including cases back to the 1990s. Okay, so we're hoping it's enough of a robust, platform that it'll be useful. So what's the Hope Impact Award for the next 2 years? So we want to finalize and just make sure there's nothing else we need to do to this gene expression signature. So one was to challenge the model, looking at progression versus transformation. And I learned that for SWOG16, we don't have information on transformation, but we do have that in a couple of cohorts from Mayo Clinic and also from other collaborators, including University of Rochester, the Leo cohort. The transformation is being collected. So we hope to get another series of cases and run it through. The other thing is, of course, SWOG SWOG16 is based on CHOP chemotherapy, R-CHOP, and et cetera. So we want to look at our bendamustine treated patients since it's such a common backbone. So the goal is to get a series of cases from British Columbia Cancer Agency. They are actually doing RNA-seq. The last I checked they had a large cohort of several hundred cases with about 75% were done. And they all treated with B plus R. We already have a material transfer agreement in place. So hopefully we'll be able to show that soon. And then the part C was, of course, the SWOG, which I just showed you. Then specific aim 2 is we really do need to look at gene mutation data and how would that contribute to the algorithm. So we're going to try to perform the whole exome sequencing on the SWOG to include, obviously we'll include all the M7 genes and other genes. At this point, we have the DNA extracted and we've sent 10 test cases to Novogene for sequencing. And then our pledge is that all the data will go back to the SWOG Statistical Center so that this follicular lymphoma information will be available for everybody who has interest in this area. And then see, what about, can we make a combined biological model? How do we add the M7 with gene expression, or maybe which one is better, and et cetera. But what about the clinical models? You're probably all going, oh, we have great clinical models. So I do want to mention the FLIPI-24. This is a this is a clinical score that was modeled on 4,485 patients, and it was developed by Matt Maurer and Jim Sirhan at Mayo Clinic in Rochester. It uses these 5 variables: age, hemoglobin, white blood cell count, LDH, and beta-2M. And you can see the difference in the survival of patients and these different groups. So again, all an effort to identify people who are not going to make it to 24 months without having an event. And you can see the survival differences in the far right-hand column of the little table, 92 all the way down to 41%. Sorry, just to go back, but let's compare that to other clinical models. I'm not an expert statistician, so what I was told was a C statistic of 0.6 is pretty good. I'm waiting for Hong Li to say, yeah, that's pretty good. 0.7 is getting better, and 0.8 is quite good. So what I'm showing you here is the FLIPI, the PRIMA PI prognostic index, and then the FLIPI-24, and you can see the C statistics getting higher as you go down to the FLIPI-24, and actually the FLIPI-24 works pretty well for overall survival as well. So what we did was put this all together and just put in a NCI grant submission that we want to do a couple things. One is take that FLIPI-20 or FL24CX, the 45 gene assay, put it into our CAP-CLIA lab, do all of the validation as we have with Lymph2CX and Lymph3 and Dark Zone, and then make it actually a clinical assay, and then go through and use that on an expanded cohort of the Leo and MER, and then look to combine what we call the tumor, the gene expression, and the clinical, which is the FLIPI-24, together, see if they add, do we need to make any adjustments, and look at a Leo-MER cohort, potentially SWOG, ECOG Akron 2408, and the potentially 1608. And we may include the M7 or other genes based on the results of the HOPE Impact Award. So that's where we are, and I'm happy to take questions. I'll just say again, thank you to the Hope Foundation for supporting us to get this done.
That was fantastic. Thank you. This
Thanks.
is really, really exciting work. I'm going to open it up to questions. Yes.
Lisa, I'll just start by acknowledging our departed Ali Press, who I think would be so happy to know that more than 20 years after that study was conceived and enrolling patients, we're still learning from it. So we should remember him. At a broader level, we've known about gene expression profiling in lymphomas for 20 years, and beyond using some immunohistochemistry surrogates, we really haven't been able to take a lot of these tools and apply them clinically. And I know that you're involved in trying to do this. Maybe just speak a little bit more about what you're doing at Mayo as far as you say routinely in the lab, you're doing this. That's probably not being widely done. And how do you see that being exported beyond the three institutions of Mayo Clinic?
Yeah, thank you. Thanks for that comment. It's a great question. So we, we're talking about doing, various studies. Often Han's algorithm is used. We know over and over again, it's about 80% accurate. So how does that impact your outcome? We still have that concern. So we do run it clinically. We run it for Mayo people, and anyone can come and ask for a consultation, and we can run it. We've published these results. Once they hit the lab, our turnaround time is 2 days. So we take external comers. And recently, Mayo Clinic Labs, the big reference lab in Rochester, has agreed to now list this on their website and let people know that it's available. And we're preparing to scale up if people are interested. As you said, the Lymph2CX, a lot of the some of the clinical studies have not quite met the mark that they were looking for. The PM3CX, or the Lymph3, which is to diagnose primary mediastinal, seems to be of interest because a lot of times you get a small biopsy, it's crushed, the immunohistochemistry doesn't work well, you don't have much to work with, and so that's where people are sending in cases for PM3CX, but it is going to be widely available. Other people have contacted us about licensing to do this, and so we're open to facilitate that. I don't know, does that answer your question? Yeah, okay, yeah. Alex, sir.
Really nice job, Lisa. That was a great presentation. I want to commend you on one of my favorite slides in the presentation of all time, just with like a prognostic factor that's just good, bad. I love that curve. But so I guess a simple question is, I mean, so far we validated this, using our historic study, but do you have plans, or is there the possibility of validating, newer regimens, bendamustine, or just rituximab, kind of all the things that we're using nowadays, or are there at least publicly available, like, will you be able to kind of use this gene expression profile that you've created, or this set, with kind of some publicly available data to try to validate it with other therapies?
Yeah, that's a great question. So I did mention our bendamustine treated cohort, but and that's available. What we're going to actually do with that is use RNA-seq data that someone else has generated, and then George will make an adjustment to run it through the algorithm and do some correlation. So where there's data, we will analyze. And like I said, we are actually doing these in real time for a small trial at the NCI as well. So yes, go ahead.
So where do you think there's a role for the microenvironment at some point to fit into this construct?
Oh, absolutely. A lot of these genes are microenvironment genes. So these genes include the IR1 and IR2. There's a lot of macrophage genes. There's T cell genes. So there's other stromal genes of interest. So they're in there. Yeah. Okay. Thank you. And thank you to
you very
Ollie,
much.
as you said.
Well, I'm gonna turn the podium over to Dr. Freeberg.
All right, so this is what's called the lightning round. Put on your seat belts because we're going to be moving pretty quickly through these studies. In light of our excellent discussions, I'll ask the speakers to be
there. So I'm giving an update on S21.
And we'll say for each person introduce themselves to
Sure.
save time.
Brian Hess at MUSC in Charleston, South Carolina. Study chair for S2114. We launched this study in the spring meeting last year. So this is the phase 2 trial of consolidation therapy following CD19 CAR T for large cell lymphoma. So again, we developed this study for large cell lymphoma patients that we deemed as high risk for relapse after CAR T-cell therapy, which we have deemed as stable disease or partial remission at that 1 month PET scan. All patients are registered, can be registered from the time that they consent for CAR T collection up until lymphodepleting chemotherapy. All patients registered to step 1 have a 1 month PET scan, which is centrally reviewed. If you have a complete remission on that central review, you're followed for PFS, followed for OS, and have translational studies going forward. Progressive disease patients are coming off of study, and then patients with stable disease or partial remission are the patients that are eligible for randomization to one of the 3 consolidation arms or observation. And these observation patients can cross over to the combination of Mosun and Pola if they progress within a year of randomization. The primary objective is progression-free survival. We'll be comparing the 1-year PFS of each of the consolidation arms versus observation. Translational endpoints will focus on minimal residual disease, not only for those stable disease and partial remission patients, but for all patients registered to step 1. Enrollment goals, we estimated that we'll need close to 400 patients registered to step 1 to randomize 120 patients to step 2. So as of last week, we had 16 patients registered to step 1. As of this morning, we have 19 patients registered to step 1. We've randomized 2 patients to step 2 and have had 6 PETs that have been centrally reviewed. So we have a lot of sites over the last few weeks to months that have been opening up studies. We still have, which will be opening up this study. We still have some sites that we're waiting on. So we're definitely expecting an uptick in enrollment over the next 6 months for sure. You know, in my site, I feel like the enrollment is going very easily. Nearly all of our standard of care patients are enrolling on this study, few exceptions, patients with symptomatic secondary CNS disease, patients with CR after bridging. But I would say about 4 out of every 5 patients that are candidates for standard of care CAR T are enrolled on the study, and it's running very smoothly. So if you're in the midst of activating the study, or if you've already activated the study and you have any questions about the protocol or any patient questions or issues, please feel free to reach out to myself and the other study chairs. And looking forward to the next 6 months, where I think we're definitely going to be seeing a nice uptick in the enrollment for the study. And happy to take any questions.
It's a great way to, get accrual credits too, because, you get credit for the left side, the step 1 registration. So that's basically anybody who's getting a commercial CAR T. I'll just ask you to make a quick comment, because I know at the beginning there were some issues regarding the central reads of the PET scans. Has that been smoothed out?
Yeah, it has. I mean, IROC's been really great with this. There was a few logistical issues with those first ones, but we're expecting those central reviews from the time that you upload the scan until to when you get that central review result and able to randomize the patient, about 5 or 6 business days. So usually at our site, we're getting these 1 month PETs, we're seeing the patient the next day, and then we expect that we'll get that result sometime the next week. And we actually hold an infusion spot for that patient 2 weeks from that PET scan. If in fact they do have stable disease or partial remission, we can just get going on giving those patients therapy if they are randomized to one of those 3 arms. So that's going well. We're also coming up with some formal plans for adjudication if there's some discrepancy in the read of those central reviews by the central readers versus the local sites.
All right, time's up. Next.
Dr. Brem was unable to be here today, so I will present S1 918. So this is a trial specifically for older patients who have diffuse large B-cell lymphoma. As we know, the curability goes down with age, and this may be due to clinical features, intolerance of therapy, and perhaps biologic features. Based on the rationale that deregulated methylation may play a role, we designed this trial of our mini-CHOP with or without oral azacitidine for patients over the age of 75 with comorbidities or anyone over the age of 80. So this trial is going well. We had a safety run-in that was a randomized element. This accrued fairly quickly. We had 48 patients. We did not detect any reason to halt the study, and so we are now in the randomized phase 2 element, and we have 69 patients who are enrolled. There's some PROs that are associated with this, as well as a frailty tool that is online. And overall, this has been, from our center at least, a very straightforward study for patients to consider. We've had a couple of amendments that have gone through to, I think, make it a little bit more seamless, but hopefully everyone has it open and available. I think this is an excellent option for older patients with DLBCL. Happy to take questions. No. Okay.
Questions on this one? All right, thank you.
Okay, so S1608, I think you've all heard about this study many times over and are aware that the one arm was closed. So just the one-liner: early relapsing follicular lymphoma within 2 years, now randomized to lenalidomide and obinutuzumab versus continued chemo plus obinutuzumab. Again, you all know that we've had a difficult time with accrual. The study is still activated, still open. There are sporadic accruals continuing to come in. We're just about to enroll our 16th patient at Rochester. So still hoping to get as close as we can to the 95 patients. But in all honesty, we're also starting to think about analysis and trying to get everything done so that we can look at the clinical outcomes and also think about analyzing the tumor specimens. Again, we had originally planned for IROC to do central reviews of the PET scans because of them moving their entire core and staffing challenges. That's taking longer than we would have liked. But nonetheless, we will have central PET reviews, central pathology reviews, and something for Lisa and I to touch on later. We have, we probably will exclude the last patients, so we don't have to wait too long to analyze the tumor specimens, but we have roughly 72 patients. Interesting looking at the pathology submitted, it's actually pretty robust. 60 some of those patients have matched specimens between diagnosis and at the time of relapse. So working with the core at Dana-Farber, we plan to analyze the tumor specimens initially, and then we will think about the serial blood samples probably a little bit later. The tentative plan is to do whole exome sequencing on all those tumor specimens, whole transcriptome sequencing, and also probably FISH for MYC, BCL2, and BCL6, allowing us to molecularly annotate these patients, this cohort of early progressing patients, as well as trying to see based on some of the studies previously done, which buckets these patients fit in at the various trials, and also do some novel exploration. And hopefully, others can also use this data, as Lisa has alluded to look at some of the transcriptome data. So that's where we stand right now. Happy to take questions offline about, as we plan to analyze these specimens, what to do with them. So questions?
I'll just remind people that that flat accrual curve, the study was closed for almost a year, while these amendments were going through when we had to close the arm. So it's not quite as dire as, you know, that curve maybe looks. That said, we're really trying to, we have like 18 more patients we have to get on this study. It's not very many. So we're hoping over the next few months to do that. And I think this will be an incredibly powerful data set, as you say, molecularly beyond what the clinical signal is.
Yeah, I honestly, we're, you know, certainly the regimens used are approved now. It still will be valuable clinical information that we'll gain, but also I think the excitement around looking at the specimens still remains. So if any of you still have it open, we'd love to enroll a few more.
Thank you.
Hi there, Debbie Stevens, and I'm here to represent the S1925 Evolve CLL study.
Your new home?
Yeah, I'm newly at University of North Carolina. And so this is the S1925 Evolve CLL study. It's specifically designed for patients who would normally be watch and wait, newly diagnosed CLL patients. We've had the study open for a couple of years now, so I'm sure you've heard about it. Currently, we're enrolling patients who have newly diagnosed CLL or asymptomatic. They need to be higher risk patients, and we've defined that as a CLL IPI score of 4 or higher, or having complex cytogenetics, and we define that as 3 or more different cytogenetic abnormalities on karyotyping. We are stratifying these patients by their CLL IPI risk score, either high risk or very high risk, and randomizing 2-to-1 to early versus delayed therapy with venetoclax and obinutuzumab, which is given per standard of care for a total of 12 months. Primary endpoint of the study is overall survival, and we have a goal to accrue 247 patients. The accrual has been quite steady, and we're at about 77 patients now, so that's about a third of the population we're looking for. But if you're still considering joining the study, we still have plenty of time, and so would love to have any additional sites, because I think this is a really important question to answer. A couple of things that I think I like to highlight when I meet with the patient, when I very first diagnose them with CLL, I do these prognostic factors, including FISH studies, TP53 mutations, and I really start talking about the study with them before I even know what their risk factors are, and saying, you know, we can do these risk factors, maybe you'll be good risk disease, and we can feel confident about doing watch and wait. It's possible you'll have high risk disease, and in the event you do, we have a study to offer that possibly will allow for early intervention. It's also a nice feature of the study that venetoclax and obinutuzumab are provided by the study. And so whether they are on delayed therapy or the early therapy, the drug will be provided by the study at no cost to the patient. One of the things that we've been trying to do to help to speed enrollment a little bit is to extend the amount of time from diagnosis until trial enrollment. And so currently this is set at 12 months from trial enrollment to diagnosis of CLL. And we're going to, the next amendment we're submitting will aim to extend that to 18 months from CLL diagnosis to trial enrollment. You can see all the other endpoints there. Happy to answer questions. And again, would love to have all your sites open this study.
I'll just emphasize, I know we've changed our practice based on the study of how we work up a new patient with CLL, particularly around the cytogenetics. Maybe just, you know, remind the group the CLL IPI factors and what complex cytogenetic tests, you know, you need to do in order to determine whether somebody is truly in this high risk category.
Yeah, and so this is a nice prognostic feature that includes both clinical and molecular effects. And so one of the biggest thing that contributes to a CLL IPI score is either the presence of deletion 17p by FISH or the presence of a TP53 mutation by sequencing. And so if a patient has one or both of those, they automatically would qualify for the study. The other prognostic factors on the CLL-IPI score, you get 2 points for having a beta-2 microglobulin level that's elevated or an unmutated IGHV status. You get 1 point each for having an older age, which is counted as over 65, or a RICE stage that is anything except for 0, so 1 through 4. So any combination of those could get you a score of 4 or higher on the risk score. It's out of a total of 10. The complex cytogenetics, probably most common way to do that would be a stimulated karyotyping. And again, we use a cutoff of 3 or more cytogenetic abnormalities to be considered complex for enrollment on this study. So if you have complex cytogenetics, you don't have to meet any of the other CLL-IPI criteria.
So I had an older patient who he had a advanced RICE stage, and their beta-2 microglobulin was elevated, and that counts. And I wouldn't normally have tested a beta-2 microglobulin, but with this, it just shows that I think there are more of these patients out there than initially you would realize. So I think if you have the study open, it's important to change your diagnostic paradigm to adjust, and it gives you more information to be able to share with the patient.
Yeah, and I think we'll get some really pretty interesting information about how the CLL-IPI score, if those patients perform a lot differently than the deletion 17p, and just kind of a really nice opportunity to study frontline, asymptomatic patients with 17p deletion too, because I think our study will be overly enriched for those.
All right, thank you.
Thanks.
Next, we're going into the ultra lightning round.
Okay, I'm presenting for Dr. Brian Teal. He's at Fred Hutch, and he's the study champion for EA4151. This is a study that asks the question of whether or not in patients who achieve a CR with undetectable MRD after first-line therapy for mantle cell lymphoma, do you need to do an auto transplant or not? So patients they can receive any type of first-line therapy, and if they're MRD negative and in a CR, they get randomized to receive transplant or not. And if they have any either positive MRD or less than a CR of a response, they still go ahead and receive auto transplant. So despite the recent I would say discussions and uncertainty about the role of transplant for mantle cell lymphoma with the Triangle study, the study is still ongoing and it's enrolling. It again tries to answer a very important question. As of October 1st, 605 patients are randomized with a goal of 689. So that it is expected for this study to go for another year for enrollment. The study actually met the primary end, met the goal for enrollment, but because of the number of patients who refused the assigned arm, namely transplant, the decision was made to basically increase the sample size to cover for that. So again, another year of enrollment, and hopefully we'll finish that in around a year from now. Happy to answer any questions that. Thank you.
Okay, my name is Boye Hu from the University of Utah. I'm the adult co-chair for AHA 2131, which is a randomized phase 3 interim response adaptive trial comparing standard therapy with immuno-oncology therapy for children and adults with newly diagnosed early stage classical Hodgkin lymphoma. So here's the trial design. An abbreviated inclusion includes newly diagnosed, previously untreated stage 1 or 2 classical Hodgkin lymphoma, and we include ages 5 to 60 on this trial. Patients are stratified into either ERTC favorable, unfavorable. If the patient has any one of these factors, they're considered ERTC unfavorable. All patients on this trial receive 2 cycles of ABVD, followed by an interim PET-2. The interim PET is rapidly centrally reviewed, and a negative PET-2 is considered a 5-point score 1 to 3. Patients who have a negative interim PET are considered rapid early responders, and those who have a positive PET are considered slow early responders and will undergo separate randomizations with the stratification factors shown here. In the rapid early responders, patients will be randomized either to standard of care chemotherapy, or the experimental arm of brentuximab vedotin with nivolumab for 4 cycles. For the rapid early responders randomized to standard of care chemotherapy, the favorable ERTC patients will receive 2 additional cycles of ABVD, and the unfavorable patients will receive 4 cycles of AVD. Notice that all rapid early responders do not receive any involved site radiotherapy. In the slow early responders, the randomization is the standard escalated BIACOT for 2 cycles, followed by involved site radiotherapy, or BV-NIVO for 4 cycles, followed by involved site radiotherapy. So we activated in April of this year with a very large goal number of patients of 1,782. The rapid central review is going well with no delays, and there's been no unexpected toxicities so far. As of October 3rd, there's been 47 patients enrolled onto the trial. Most of them have come from COG, given that this is a COG-based study. And there's been a pretty good breakdown, about 50-50 between pediatric patients less than 18 years old and also adult patients 18 and older. There's been a slightly more unfavorable ERTC patients, but I think this will sort of probably settle out to become more in line with the prior ERTC stratification as we enroll more patients. And happy to take any questions or any concerns about the trial.
So this is going to be open for a while, given the sample size, but I think it's a very important question. And, you know, patients, once you have the discussion with them, I think are very excited about the possibility. I have my first patient who's gone through the treatment. We've learned a few lessons. One, I'll say that the turnaround time on these PET reviews is very fast. I think it was in about 24 hours, which was good, but our site had to get all the information to them, and that took way more than 24 hours. So you have to, you know, understand. Another subtle point is that the BV-NIVO is every 3 weeks. These patients are used to an every 2-week schedule. So, you know, just be prepared for that if somebody gets assigned to that arm. And the last thing I'll say is that the consent form is a long consent form. They use the COG template for the consent form. It's like at our institution, 39 pages long, which, you know, can be a lot. I spoke to COG about that. And in fact, the leaders of COG were hoping they could use the adult, you know, templated consent forms for this, but I guess COG didn't let them. So be prepared for that. But there's accompanying material that has these flow diagrams that I think make it very easy to go through what the intent of the study is for the patient. With those caveats, I think, you know, the patients are very excited about this. And I think we really should try to participate as heavily as we can. The COG did a really good job on our study, 1826. And I know this is really just getting started in the adult groups, but I'd hope that our committee will support this highly. Thank you.
Okay, I'm back. Jennifer Amagold from Columbia, and I'll be talking about a randomized phase 2 study of duvelisib or azacitidine in addition to CHOP or CHOEP for CD30 negative T-cell lymphoma. And super briefly, as this audience all knows, PTCL does remain a major challenge in terms of treatment. We've made some great headway in CD30 positive disease, but those with CD negative PTCL still have really inferior poor outcomes. There's been lots of work looking at oral azacitidine in this setting, as well as duvelisib, which is a PI3 kinase inhibitor, which have both shown really nice response rates in this disease. So this led to a study that will be looking at frontline or a newly diagnosed CD30 negative PTCL. Patients will be stratified by T follicular helper subtype, and then patients will receive either CHOP or CHOEP based on their age. So greater than 60 patients will receive CHOP and less than 60 CHOEP, and the patients will be stratified by age in this backbone. Patients will be randomized 1:1:1 to duvelisib plus CHOP CHOEP for 6 cycles. Azacitidine, this is oral azacitidine plus CHOP CHOEP, and or just CHOP CHOEP as a background. And the primary objective is a complete response rate with secondary objectives of toxicity, PFS, overall response rate, duration of response, and we'll be looking based on TFH subtype and correlating interim PETs with response. So the just to kind of go over the treatment schema real quick. Basically with duvelisib, we've had a nice safety run-in, and it was determined that this was safe and feasible in patients. And essentially, this is pretty simple. Patients get duvelisib on days 1 through 21 throughout the treatment twice daily. And there'll be ctDNA collection weekly for the first cycle and then at the end of treatment. For the oral AZA arm, it's a little bit more complicated just in terms of the dosing schema. Patients get sort of a priming dose of 6 days of oral azacitidine and then go on to receive CHOP or CHOEP and then resume oral azacitidine on days 8, sort of to kind of prime for the second cycle. So they kind of have a week off of oral azacitidine with each cycle, sort of the first week after CHOP. So far, as I mentioned, the safety run-in is completed. There were no concerns with the PI3 kinase arm to date. And we're already, the randomized portion is open and activated. The first 36 patients will be included for additional safety checks. So there'll be 18 patients over the age of 60, 18 under the age of 60, and we'll continue to have safety calls if you have patients enrolled in the first 36 patients or so. At this time, there'll be in the randomized portion, there are patient-reported outcomes, requests for slides, and ctDNA will be collected. And there is an allowance for using digital submission of slides for review. So far, SWOG, I think, has enrolled 3 patients, and so hopefully we'll keep that going, and we're excited to see how this reads out. Any questions? Okay.
This one was closed for a bit of time and now it's going to be open, it sounds like. Pretty
Yeah,
shortly.
absolutely. It was just closed to evaluate the safety, which was fine.
Thank you.
Okay, I'm back to present an ANHL 1931 for Manali Kamdar, who is the SWOG champion for this study. This is the randomized phase 3 intergroup trial of chemoimmunotherapy with or without nivolumab for the frontline treatment of primary mediastinal B-cell lymphoma. And so patients enroll onto this trial and the physician declares a chemo backbone, and then the patients are randomized 1-to-1 to receive either just a chemo backbone or chemo backbone plus PD-1 inhibitor. In this case, it's nivolumab. There's some end of treatment PET scan decision-making as well, depending on the response. The primary endpoint of the study is progression-free survival. Secondary endpoints of EFS, OS, and rate of PET positivity, and exploratory objectives are being performed by Dr. Bollard's lab at CNH. And so the accrual updates right now requires 186 evaluable patients with 102 patients enrolled. I actually just saw like an accrual curve for the study, and they're actually accruing faster than expected. And they may finish actually quite early. There's been no major toxicity signals seen, no major amendments. There's just a minor amendment in progress, which is increasing dose reduction for neuropathy. And you can see the breakdown of the accruals and who's been accruing. And again, this is a COG-based study, so they are doing incredibly well in terms of their enrollments. SWOG is there, but we could probably pick it up a little. And that's it.
All right. Have we finished? I think we have 2 minutes to spare, which is settling my stomach because I was a little worried if we were going to get through it. Anybody have any final questions? I really want to thank our working group in particular. Obviously, most of you are here, but I'm speaking to the almost 40 people who are online as well. Our working group has done a terrific job of really thinking about these studies. I think the portfolio in general in lymphoma and our SWOG portfolio in particular is as robust as it's been in the 20 years that I've been part of this group. So we should all be proud of that. We have some very exciting studies coming up, particularly one in follicular lymphoma that we'll be talking about in the spring. and some early concepts and discussion around marginal zone lymphoma and older patients with Hodgkin lymphoma. So I think we're going to continue to round out the portfolio. We can only do it with your support. Thank you so much. Safe travels for those of you who are here. And Dr. Stiff's transplant committee is starting in 1 minute. So many of us will be there. Thank you.